review pediatric ketamine. So, the keys, the objectives are that ketamine for pediatrics and just overall is not a first line analgesic medication. So, pediatrics are the highest risk group for the side effects to occur. So, that's why the patch point of less than 18 years old is in our medical directives. That's there to substantiate they do need ketamine. Maybe they need morphenol, maybe they need morphine. Or if there is indeed indication, the base hospital physician agrees with the order, then you have that piece to say, hey, this is their approximate weight. This is the dose I'm thinking. Do you confirm that? And you can actually review the math and how you drew it up and how you administer it. So that's why the patch point's in there. We'll make it as abundantly clear as possible because the patch point for ketamine differs from our opiate medical directive for less than 12. So you can see how that causes some confusion. But again, we're just trying to hammer in that point. Furthermore, you can see that giving very small analgesic dosages for the highest risk population with a current concentration of 50 milligrams per mil is not conducive for accuracy and precision in administering this. Use as many resources as possible. Use the dosing chart that we provided. Evidence has clearly demonstrated that if we use dosing charts and other healthcare providers, that we substantially reduce the cognitive load we experience, and we also reduce the amount of errors that can occur. Because if you look at the empirical evidence of EMS systems around the world, there's one came out of Michigan that approximately 34% of pediatric patients experience some sort of medication error, and they are at higher risk for serious adverse effects. That's why I use the dosing chart. We have all the patient's weights, we have the corresponding mils, and we actually have methods and reminders how to draw it up safely and effectively. Because if you're doing the intravenous route, we should dilute it for safe medication practices to ensure that you can administer it slowly over 2 to 3 minutes. Because usually the side effects occur when healthcare providers fast push it, especially at higher dosages. There is a clear association between the side effects. That can lead to apnea and transient apnea. So that is not a good side effect to experience. There are less than 1% of the population, especially pediatrics, can experience laryngospasm, and that would be evident from stridor, respiratory distress, maybe alternate level of consciousness. It's usually self-limiting, but we do have to treat it with basic life support maneuvers, good airway management, good oxygenation and ventilation. And there's that Larson's maneuver where you put your fingers under their jawline and technically and theoretically should alleviate it. So everyone's got to be aware of that. Also, hypoxia can occur, especially if you stop breathing. That's a complete corollary, and nausea, vomiting, and there could be some agitation. If you talk to our colleagues in the in-hospital system, usually when they give ketamine, especially if they give higher dosages of ketamine, they'll put them in a separate room. They'll turn down the lights. When they slowly wake up, it's slowly and very specific and very comforting. Not with someone with a yellow uniform staring at you, waving at you, how is the K-hole? Not the same environment. So we have to be cognizant of that. So let's say this is 50 milligrams of one. And let's give our classic example. You have a 4-year-old. So we patch, they said, yep, go ahead. And we start calculating our dose. So if you have a 4-year-old, we do the classic age times 2 plus 10. So they're approximately 18 kilograms. So based on our medical directive for the intravenous route, that's 0.25 milligrams per kilogram. And that equates to 4.5 milligrams, or about the mils, because that's how much we physically have to drop to get that dose. And if you look, based on that concentration, that's 0.09 mils. So I like the visual example of using 1 mil syringe because you're using very fractional dosages. It's hard to overdose them when you're using this type of syringe. So I like that safety aspect of it, but it's hard to actually get 0.09 precisely and accurately. So Dr. Moran and Katrina have supported that we can round to the nearest 0.05 mils like we do for epinephrine. This aligns with our medical directive. There's a verbiage in there that says drug dosages are hard to precisely get, and you can round accordingly. So just based on safe medication practices, you can round to the nearest 0.05, and there shouldn't be any negative ramifications with that. So if we give a prime example, this one is supposed to get 0.09 mils. If we round to the nearest 0.05, that corresponds to zero point 0.1. If you want an abstract example to further prove this point, imagine you have to drop 0.63 mils, then you round to 0.65. An inverse to that is if you have to drop 0.62, the nearest 0.05 is 0.6. Document on the ACR that you rounded for those reasons. That's totally fine, acceptable, and best medication practices. So if we go back to this, we rounded to 0.1 now, which is equivalent to 5 milligrams. Then you drop 9 mils of saline. So now you have 5 milligrams of ketamine in a 1 cc syringe, and you slow push that over 2 to 3 minutes. But again, you can appreciate the human factors of this. How often do healthcare providers in general sit there and do this? After about 30 seconds, you're like, I am bored of this. So some services in our catchment area have the pediatric stop and cocks, which is incredible. That's awesome. So another way you could do this for the intravenous route is that we know 50 milligrams per 1 ml is our concentration. So if I have a 10 cc syringe and I drew up 2 mils of ketamine based on that concentration, I have 100 milligrams. Now, if I drew up 8 mils of saline, I now have 100 milligrams in 10 mils or 10 milligrams per mil. And let's say my dose for this patient was 10 milligrams. I can now use the pediatric stop and cock, put it on here, and attach the 1 cc syringe and drop 1 mil. Because again, that relates to 10 milligrams. I now have 10 milligrams in 1 mil, and I can slow push this over 2 to 3 minutes. And if you do it this way, it's more difficult to overdose them. Because if I left in the 10 cc syringe and I didn't waste down to my dose, I could accidentally give more than is indicated for that patient, and then subsequently leads to negative implications. So pediatric stop and cocks are very versatile and beneficial for those reasons. The best practice guidelines for pediatric analgesia actually do recommend the intranasal route. It's quite bioavailable. You don't have to use a shark. It's quite potent and effective. Because if you look, like how often do we do pediatric IVs? How successful are we at them? Do we really want to be doing them, increasing our anxiety and the patient's caregivers or parents or learners? What are you doing? It's like, I don't want to exacerbate an already stressful situation. If you can get an IV, that's great. And everyone's for it. That's awesome. But again, if we have the intranasal route available to us, you can do that. So if we look at the intranasal dosaging, that's 1 milligram per kilogram to a max of 30 milligrams. You can give 2 dosages again, 15 minutes in between, and you don't have to dilute it. We only dilute intravenous medications for safe accuracy of the dose and just a slow push to mitigate the adverse effects. So the overarching theme of ketamine is that, again, it's high-risk medication. The highest risk population is pediatrics. At the concentration we currently have, it can be difficult, but again, use every resource at your disposal to mitigate the side effects. Reminder how to dilute it safely and effectively, and do the independent checks and slow push it over 2 to 3 minutes and have that base hospital confirmation if they're less than 18 years old to ensure they do need kit. Maybe they need an alternative directive or a drug, and just ensure the accuracy and the precision of the ketamine dose you're supposed to give for that specific patient.